Okay. So we are going to have comments throughout the show. We might not get to all of them during the show, but we will get to them in the viewer's voice. So if you think I'm ignoring you, I am not. I see all of you, and I'm very grateful for all of you. So we're going to bring in Dr. Rob now. Where is he at?
I am here.
Hey, Rob, how are you?
Right on. I am awesome. How are you, man?
I'm doing well. I'm glad you came in early tonight. Once again, it seems like every week there's like a new technical challenge to face. And yeah, we both had our struggles, but we're both here. So, are you ready to dive in?
I'm ready to dive in, man.
Okay, man. Well, why don't you tell us a little bit about what motivated you to get into addictions medicine in the first place?
Sure. Honestly, I initially started into addiction medicine to be a better pain physician. And, I grew up in Southern Alberta, still live in Southern Alberta. And with that, a lot of friends and family really struggled with addiction and started really learning how kind of messed up the field was, and really how we weren't following evidence-based treatments, and it was just a bit of a disaster. And I think I kind of fell into it from that point, and I really thought, this is where I want to spend some time, and I think we can make a big difference, and kind of been here ever since. And I think, like so many people, I've lost people who are close to me over the last few years in the kind of opioid epidemic, and I think that kind of pushes me to stick around even more.
Yeah. So you were already in the field when the onset of the opioid crisis happened, correct?
Yeah, I had kind of came into the field just at the onset, and we were kind of seeing these, heroin wasn't very popular in Alberta. We started seeing more heroin, then we started seeing the fentanyl, or at that time, green beans is really what they were, shady 80s. And you could always tell when somebody was struggling.
I did 5 years on the shady 80s.
Yeah. Fair enough. So that was a tough time. I mean, we were seeing a lot of kids and a lot of people who thought they were taking basically their oxys, and
that's what I thought.
They weren't, and they were really struggling.
Yeah. So did you foresee what was coming when
foresee, I don't know. Nobody could have foreseen this. Who would have guessed? But at the same time, I remember doing a lecture in Toronto about 5 years ago or so, and listening to the Toronto docs kind of laugh about how they're not going to have fentanyl, and they've got enough heroin on the streets and methadone clinics on every corner. They would never have to really worry about it. And, of course, we've seen these waves happen more than once. PCP started on the East Coast. Fentanyl started on the West Coast, meth started on the West Coast. So we see this happen, and it slowly works its way across North America. So really not another kind of unexpected outcome is to see it start on the West Coast and work its way across the North America.
Yeah. So what went through your head when you started to realize the level of ignorance in that community?
Oh man, what goes through your head? I think that I remember as a fellow, so this is where I had finished all of my training. Now I was doing extra training in addiction medicine, and I had advocated so much that where I was training, they weren't even prescribing Suboxone, let alone methadone or naltrexone or any other medical treatment. And they really called themselves a mental health program, but they didn't really focus on mental health either. And so I really advocated, even saying I can probably get enough residents together to prescribe the Suboxone if they just let us do it. And they simply said, there's already opioid clinics out there, people can go there. Which, we knew the patients that we were treating at that time there weren't going, and I wasn't even allowed to prescribe the Suboxone. Of course we did anyways, but just that's how messed up it was.
Yeah. Yeah. So you have experience with abstinence-based strategies as well as harm reduction strategies, correct?
Yeah, I mean, I think that everything we do when we start in prescribing opioid agonist therapy is a harm reduction protocol. It's about getting them on something safer than what they're using and reducing their risk of overdose. And then we work with people along kind of a continuum into abstinence-based treatment. But, a lot of people might not be able to completely stop all of their opioid agonist treatments, and that's okay. the key is to get them to the lowest optimal dose. And for some people, we can taper right off. And for other people, we're not able to do that. And that's the individual part of treating in, patients is working with that person one-on-one and finding what works best for them. But certainly I've helped a lot of people come off of everything. And I still get kind of cool emails and letters. And I mean, buddies kind of bug me all the time. I'm a doc, I actually save lives. And I chuckle and say I'm a doc, but I change people's lives forever. So I think that's more important.
So when you look at because there's clearly a rift between the abstinence-based community and the harm reduction-based community. And, let's be real about it. I mean, are you seeing stigmatic barriers in each respective community that's standing in the way of progress?
Yeah, for sure. And it's an artificial divide. Everybody wants to try to help, right? It's not like people are like, oh, I'm not going to stick to that side or the other side. Yeah. But we do see it sometimes where you see some recovery individuals believe that anything in harm reduction is the wrong way, which really is everything we do at addiction medicine at the beginning. And there's some people who believe that, treatment and recovery doesn't work, which is insane. To believe such a thing. I mean, I read one tweet recently that mentioned 95% of people don't respond to treatment. And I was like, where does that come from? Somebody just made up a number and they're like, that's it. 95% just won't respond to treatment.
Yeah. How can you meter? How can you meter that? Like, what is the measure of success?
I don't know. People pulling shit out of their head. The reality for us, what we look at is, can we keep people in treatment and engage with what we're trying to do? Can we get them into evidence-based therapies and trauma therapies? And can we get them to stop using whatever they're using because they don't need to use anymore? That's the ultimate goal. At the beginning, it's making sure someone doesn't die. And at the end, it's to make sure somebody is, back to the life that they deserve like anyone else deserves.
Mm-hmm. So what's the science saying then? What's working out there?
So, the gold standard is methadone, but the first line treatment for opioids, when we're speaking about opioids, first line treatment is Suboxone or Buprenorphine Naloxone. Suboxone is like saying Kleenex instead of tissue paper. And there's your first line treatments without question. That's 1A and 1B. They've been around a long time. We absolutely know they work. We absolutely know they save the healthcare system money. We absolutely know they reduce the risk of overdose and death. We absolutely know that we can stabilize people and help them along their journey of recovery. And people can do trauma therapy while being treated with opioid agonist therapy. People can do anything that they need to do. And again, some people can do well, come off. Some people struggle. At the end of the day, we also know that true addiction treatment includes a combination of addiction medicine and addiction counseling. And, we're trying to push it one step further, that it should absolutely include trauma therapy when indicated, which is actually the vast majority, not some minority. And so when you start putting all of that together, you start building skills and you start using anti-craving or relapse prevention medications and opioid agonist treatments. And, we start treating the underlying root of the disorder. That's where we get the best outcomes. Okay.
I have to admit, I forgot to turn the ticker on. It's on now, though. Yeah. The first go, something's got to go sideways. So, okay. So, I mean, what's not working? What are you seeing out there that people are preaching and is not working?
Yeah, I think that, at the end of the day, there's this kind of biomedical approach to addiction that people are trying to push. And, we've seen some HIV physicians and internists and emerge docs, all so well-meaning, but their entire training background is really in understanding the diagnosis and prescribing. And looking at that biomedical approach, they're looking to prescribe a medication, they're looking for a simple, easy answer. And if only it was as easy as pick a medication and cure it like you're curing an infection. Unfortunately, addiction is not an infection and shouldn't look as one either. On the other side of the stuff that's not working is, the pull up your boots. Addiction is just a behavioral concern. It's your problem, suck it up, figure it out. also not appropriate. And the true answer is the balance. And of course, when you start looking for easy answers, then you start seeing things like, if I just give them this medication, everything will be fine because it's so-called safer. But there's no evidence to support that at all. And at the same time, we're just going to throw them into a long-term detox and they'll be fine once they're off the drugs. There's no evidence to support that either.
Mm-hmm. Yeah, Aftercare is... Tell us a little bit about what Aftercare should look like, Doc. Let's go.
I mean, if you want my opinion, Aftercare should last a minimum of 1 year. Yeah. And, the way we've tried to design it is to include seeing your doctor once a month, seeing your therapist once a month, and doing group on a weekly basis with kind of your group that is your alumni, the people that you graduated with, and working with them and staying with them over that year period. And if things start to slip or something happens, well, that's an opportunity to figure out what happened and let's deal with that and let's move on with it. I think that's another big problem that we see is, people being taken advantage of is you slip or you have a relapse in treatment and you're kicked out.
You get kicked out.
I mean, this is the ultimate opportunity to
you're too sick. You're too sick. Get out of here.
You're not fitting our cherry-picked data.
Yeah. So hang on a sec. We have to celebrate here something for a minute.
All right.
We have someone celebrating 3 years sober from alcoholism today. Congratulations, and Thank you for being here, and thank you for sharing that with us this evening.
That's awesome, Tawny. Congratulations.
Absolutely. Okay, so what roles are you seeing generational trauma playing in the opioid crisis?
Yeah, I think it's a major problem. I think that when we start thinking about what intergenerational trauma is, then we got to start figuring out, well, what is trauma in the first place? And really start understanding where trauma comes from. So it was probably, if we go back, it was probably Freud that really started digging into understanding how your childhood affects who you are today. Of course, he blamed everyone's mom, but he was also doing a lot of cocaine at the time. So, and if he would have kept going and tried mushrooms instead of just realizing, hey, cocaine's not doing any good here, he might have found the magic cure there. But
if we could turn back time.
Yeah, right. But the problem is that, Freud, he kind of stuck on one thing and stuck on the mom. And then we kind of shifted into cognitive behavioral therapy. And we started really focusing on Band-Aid like techniques that our goal here right now is just to deal with the wound rather than trying to figure out what caused the wound, what's in the wound, what's happening with the wound. And now we're starting to shift back to that. So there was the first trial with the adverse childhood experiences, which I wish we would just change that term to adverse childhood traumas. Being raped by your uncle or watching your father violently attack your mother is not an experience. These are traumas. And so these childhood traumas put you at much higher risk of mental health, addiction, lung disease, cancer, poor education, poverty, so many things. Like, they affect your entire life. And so that's the first step, is let's start looking at that. And that's where intergenerational trauma can really come in, because when you have this trauma, it affects your genetic code. It activates and deactivates different genes, or what we call epigenetics. And those epigenetics are passed down to our sperm and eggs, obviously male and female. So when we start changing the genetic codes that are turned on and turned off, we have to do a lot of work afterwards to affect how that individual can turn on and off genes as they're developing as a child and into an adult. So we know more trauma in a child affects the brain's ability to develop its frontal lobes or its executive functioning, and also affects our HPA axis, which really is our stress hormones and the releases of different stress hormones in times of stress. So not only can you not kind of see stress coming, when it hits you, you can't deal with it. So it affects your entire ability to be resilient. And if you lose resiliency, it puts you in a difficult position where mental health and addiction concerns can really start to kick in. And this is why we shouldn't be asking people, what did you do? We should be asking people, what happened? What led to this? And let's really figure it out and working with people rather than blaming people.
Right.
When we think about epigenetics, Epigenetics can happen regardless in that intergenerational trauma. Our indigenous populations in North America, an entire culture that underwent genocide, and are still kind of surviving that moment in a culture that still doesn't really accept them, puts it at a real difficult process. But we see intergenerational trauma in poverty. We see intergenerational trauma in certain other areas around the world. And so, if you grow up in a family that was full of violence and drug abuse and alcoholism and mental health, you're likely to grow up and become the father of that same family and repeat the same cycle. And that's really what we talk about when we think of intergenerational trauma, is the repeating of a cycle over and over and over again, rather than trying to figure out ways to break the cycle. And really, if you want my opinion on how to break the cycle, we should take all of our healthcare resources when it comes to prevention and put it towards every new mom or parent having a new baby, so that they have every resource known to man around them, so that they're protected. They learn about traumas and how they affect the brain and how to raise their children, and to be supported in times of distress and stress, which really where a lot of those childhood traumas can come from. So in short, as that was a very long monologue, in short, it has a major effect. Trauma has a major effect on our current addiction pandemic, if we want to call that. Certainly, it's an epidemic here in Canada. And we're seeing, there was just a published report showing doubling the amount of hepatic injuries due to alcohol in hospital.
What's hepatic?
Since COVID. So liver injuries. So really, we're seeing more and more alcoholism and people really struggling. And
it's interesting, isn't it, how that alcoholism is a bigger problem than what we're experiencing in the opioid crisis. And that's, anybody that knows anything knows that, but nobody's talking about it. But while I've got you here, we've got a couple of questions here. I see Marie, I see you there. We're going to go to Donna's first. It's a little bit more where we're at in the conversation. So Donna says, is that why there is an increase in ADHD diagnosis, or is there simply a higher tendency to clinicalize behavior?
Man, that's a tough question, and I don't think anybody's figured that answer out. I think we as clinicians, we've become better at diagnosing it, but we also further show more and more structure in our schools, forcing children who maybe can't sit that mold of being able to sit in a chair and focus all day long, sitting at a table, staring at a blackboard. But we're seeing schools starting to adjust too. So my kids' school, for instance, they have bouncy chairs and things to fiddle with their hands, headphones that they can put on to listen to different tunes and
That's
sounds.
Wonderful.
All these sensory things to keep people stable. But at the same time, ADHD is a real diagnosis and can be life-changing when we add the medical treatments for that.
We've got another.
In other words, I don't have an answer for that question because nobody really knows. But
I forgot what the question was already. Okay, we've got Marie here. Thank you, Marie, for watching tonight. It's good to see you, my friend. One of the barriers we met has been the reluctance of some medical schools to increase their training in addictions. Are you seeing any changes?
Yeah, the Association of Faculties of Medical Schools of Canada, which is a lot of OVs, the AFMC, is putting together a complete curriculum for all medical schools across the country to learn about the simplicities of prescribing buprenorphine naloxone, all the way to understanding childhood traumas and how to communicate with people suffering with addiction to try to break some of the stigma and improve access to treatment. There's no question there's been some difficulties in different schools, but I've been lucky enough to work here at the University of Calgary and the postgraduate medical education. So this is the group that focuses on people who finished medical school and are training in certain specialties or disciplines. And we've managed to almost get every single discipline and specialty in Calgary at the university to get at least a 1-hour course. And I know 1 hour is not very much. I do them myself and ask for much more. But at 1 hour, anywhere up to 2 full days of education on addiction and the effects and outcomes of such. So we're getting there. But for sure, I mean, when we're changing a whole generation on how to look at something, it takes time. And even though there's a lot of angry people who want to yell and scream at everyone for not listening, it takes time.
Mm-hmm. So let's talk a little bit about return to work. I am a tradesman in recovery, and I was treated poorly a lot. And I was never really offered resources, and not because I had bad employers. I had great employers. They were wonderful people, but there was no resources available to them, and they didn't have the training that they needed to address the problems. They just saw the behavior and acted accordingly. What can you tell us about an effective return to work plan?
Yeah, so that's a great question. You know, I do a lot of work in that area, being a psychiatrist, who then went on to finish a fellowship in addiction medicine. And then after that, I was cross-trained by anesthesia and pain medicine. And so those are the three major reasons people are off of work. So I've been kind of working with different private companies and insurance companies to support and help people get back to work for those reasons of my training. The really important thing is identifying the correct diagnosis and then working with that individual. Often we see people who are struggling with addiction who are often struggling with some sort of mental health disorder as well. But we ignore the mental health disorder. We put them in peer-led programs, or even worse, as you mentioned, we just see the behavior. We don't even understand the addiction or the mental health, and that's a lot to do with the stigma of where we sit today. So the first thing is education, and then identification and correct diagnosis, and then from there putting
education
together really
education for the employer,
employers,
right. Okay.
Employers, case managers. So we're doing a lot of lectures. For these individuals, and we're seeing massive shifts. We're seeing insurance companies having highly trained PhD psychologists working on their teams,
disability management specialists.
Absolutely.
Why isn't anybody saying disability management when we're talking about drugs at work? Like, why?
Right. That's what it is.
Exactly. That's what it is.
Yes.
So, okay, what else? I'm sorry, I cut you off there. I had to get that rant out. Please continue.
You're totally right.
Yeah,
we need these disability managers and disability experts, really, because this is a rehabilitative process. And so when we make the right diagnosis, often what we see, if we went back the last kind of decade and a half, it's always about if it's addiction, you treat the addiction. If it's mental health, you treat the mental health. But nobody's really putting the two together, even though addiction is a mental health disorder. And in fact, I'd love to ask all your viewers if there was a way to do a vote. I mean, the question is simple. Is addiction a health disorder? That's it.
Well, put your comments in
primary health disorder.
Put your comments in the chat and we will look at them during the viewer's voice.
Awesome. Now, I have my opinions, and you're going to guess that really quickly. Of course it is.
You don't have strong opinions, do you?
Yeah, no, not at all.
Me neither.
So it is a health disorder, and it should be treated like a health disorder. And that means identifying the primary diagnosis and then the secondary diagnosis and treating them all. So we know when somebody has addiction and has PTSD, if we don't treat the PTSD, it's one of the highest risks of relapse. So, sometimes even higher than hanging around with other people who are using. And yet we see very little programs across this country. In fact, I can count them on one hand that are treating the underlying PTSD. Many of them will diagnose it, several weeks in when they start saying, I don't know, things don't seem to be adding up. We're going to bring in our psychiatrist and have him see him now. These aren't medically managed or medically supervised programs. These are just programs that have consultants working there. And what we really need to do is we need to get good psychiatric assessments, addiction medicine assessments, pain medicine assessments, everybody working together and then coming out with a true diagnostic plan and outcome so that we can actually focus on all pieces that would interfere with somebody's return to work. The reality is so many people have such little understanding of PTSD. Most would suggest that PTSD is a palliative disorder. It's not palliative. It's fully treatable. Waking up with nightmares and cold sweats, unable to breathe, seeing things in your life that trigger you off, almost feeling like you're reliving the experience again. All of that can go away with good evidence-based trauma therapy. And one of the major reasons people do use substances is to avoid all that. I don't want nightmares anymore. The alcohol puts me to sleep. Mm-hmm. I don't want to think about, what happened to me as a child over and over and over again, but I take a pill and it's gone. And then unfortunately the way, some of these substances work is that you need more and more and more and more to get the exact same effect that you're looking for. And you never get the effect the way it was in the first place. Otherwise, we'd use opioids for the treatment of PTSD.
Yeah, it's called chasing the dragon.
They work very well. Chasing the dragon. That's
chasing
exactly
that dragon.
It, right?
Never as good as the first time, man. Never as good.
Never will be. Now, that's the funny thing. The only way it's better is if when you rotate from heroin to fentanyl. And
don't be giving people ideas. So that's how I do it.
It's
thanks, Doc.
The more potent, yeah, I know that was a bad one. I guess.
Boy, we're no, it's okay. I'm bugging you. We're getting a resounding to your poll there. We are getting a resounding yes in the chat right now. Holy cow!
Of course.
Yes. So continue,
and
please.
Yet, when we think about that, so let's go to that. So a resounding amount of people believe that it's a health disorder. Yet we have harm reduction facilities with no doctors working in them. No access to treatment. We have abstinence-based recovery programs with no doctors working in them. No real treatments intermixed with it. So we can all sit here and know that this is absolutely a health disorder, yet we have so many facilities where there's no health care. And that's what's really mind-boggling to me is, really knowing that from an addiction medicine perspective, we look at addiction as a medical disorder and we treat it as a medical disorder. No different than if I were treating PTSD or depression or, treating inflammatory arthritis. I'm treating a medical disorder. It may be chronic. It may be remitting and relapsing for some people. Many people can completely recover from it. And we should be adding every piece in our arsenal to help someone get well. Not, well, try this first. Oh, that didn't work. Try that one now. Oh, that didn't work. Go to try that one now. And that's kind of how we do things. And maybe a doctor might not be till, step 3 or 4 before somebody actually tries that route.
Yeah. Yeah. So let's talk. What are you learning about psychedelics? Because this is getting pretty fringy, man. Like they've been doing these studies for a long time, but you're making it happen. Tell us a little bit about what you're learning as far as treating trauma with psychedelics.
Yeah, so I would say that the MAPS group have really moved it beyond fringe anymore.
What's the MAPS group?
So the MAPS group is the Mdma research group and advocacy group who've been around for a long, long time. And they've been advocating, but they've been doing it with science, which, nothing better than that. It's not about my people need this. It's about the data suggests that this is a really good treatment. And they just finished a phase 3 clinical trial. Phase 3 means that they've done animal studies. They've got all the information there. They did a small little study with a group of people for safety. It wasn't really harmful. Then they moved up and did a larger study with a larger group and got a really good outcome. So using MDMA for PTSD. Then they did a multi-site, multi-center trial it worked out to about 90 people with pretty severe PTSD. They had veterans from Vietnam. They had people with childhood traumas who were in their 30s and 40s. People who've been living with trauma for many, many, many years. And with the MDMA protocol, they were able to get about 75% complete remission in people who were basically considered treatment failures. That's
what kind of time frame?
That's incredible. It was 3 sessions.
3 sessions.
That's it. 3. Now they're 8-hour sessions. They're long.
Well,
and there's intermittent therapy in between. I believe like eight therapy sessions on top of that. And I could be wrong, and one of the viewers can correct me there.
I've used MDMA before, and yeah, that's a good 8-hour session.
Yeah, so for sure, except they're using massive doses. So
really?
For instance, the psilocybin dose is anywhere from 8 to 16 grams of psilocybin.
Holy shit,
so
man.
Imagine 8 to
Here,
16
I thought you were gonna.
grams.
I thought you were gonna say, "Oh well, we're microdosing over a long period of
No,
time," and you're like,
no.
"No, we're feeding them to these guys." Like,
It's got a macro dose. There's no evidence for microdosing.
Wow.
Microdosing is the biopharmaceutical industry's plan to create another antidepressant.
I would be scared to do
every
that.
day.
I would be scared to do that much mushrooms. Like I do like the most I ever did was like an eighth, and I was like nervous. I was like eating them. I'm like, oh
Right.
man, I hope this turns out okay.
I don't want to puke my guts out.
Yeah.
That's why you need a good team dedicated to sitting and supporting you. There's 2 therapists in the room with you. There's usually a music track, and you're usually blindfolded through the process, so you're a bit of sensory deprivation that goes with it.
Wow.
Some really good protocols. The psilocybin for treatment-resistant depression, the Yale protocol is to add in acceptance commitment therapy. Now, you heard me, Yale. We're talking about Ivy League schools researching this, not fringe stuff on the side. The University of Calgary is just about to hire a chair. That's how prominent this has become, is they're hiring a major lead who's a researcher who can help lead all the research in psychedelics here in Calgary. And we're really going to start seeing that this could be something that's real. Now, today, what we're really seeing is these exemption 56s are treating palliative individuals, people who are at end of life and struggling with their mental health, and then they get access to this treatment. I would suggest that probably in the next 5 to 10 years, anybody during time of death is going to be offered this during their palliative course of treatment. And this will be a normal piece of what somebody goes through. I don't think anybody's ready to die, regardless of what some people may say. And so this really can help that process. And really what psychedelics do, it's kind of like, 5 years of Freudian therapy jammed into 8 hours. So, and then you add on skills and good trauma therapy, and our expectation is, we might see 90 or even higher percentage of people with workplace-related traumatic injuries completely resolved within a couple of weeks. These are crazy. Usually things that go on 8, 10, 12, 14, even 30, 60 weeks of therapy.
I've been in my healing path for like 4.5 years, and I still have days where I get back into it, into that mindset, and they come back. So what is it about the psychedelics that's working? I mean, we talked last week, and we were talking about being able to move past stigmatic barriers that we weren't even aware that we had. Like, let's talk a bit about that. Like, what is it?
I think that's what it does. It's a catalyst. It opens things up. So when people who have pretty severe traumas, or even worse, the really severe childhood traumas, nobody wants to talk about it, right? Nobody really wants to open up, and that's Pandora's box. If you're opening it up, man, you better be ready.
Absolutely.
And people aren't very keen to open it up. What the psychedelic journey allows you to open it up, but do it internally. And process a little bit of it and see where it's going. It's a non-directive type of psychotherapy, so we're letting the patient follow suit with what's going on for them. If they want to talk to a tree on a frog on a log, they can talk to a frog on a log all they want, and we're not going to direct them any way out of it. But what it really does is it seems to work on our conscious. And this is why animal studies don't seem to translate very well, especially with ketamine. They just don't seem to cross over as well. And I think that there's a level of consciousness that the psychedelics have an effect on that other medications just don't seem to do. But they really, exactly what you said, they break down the barriers that we put up as defenses to prevent anybody from harming us because we've been hurt. We've been hurt really bad, so bad that I'm all messed up and it's screwing me up. I'm not letting anyone hurt me again. And it brings that down and opens someone up to doing good therapy and good trauma therapy. And that's the way we're looking at it. It's a true catalyst that works on an area of consciousness that we don't quite understand why it works the way it works and as well as it works.
I see all your comments. I'm not missing them. We'll get to them. We might be here for a while in the viewer's voice. Okay, so let's talk about the justice system. How is the justice system standing in the way of all this? I'm just gonna
Well,
put you on.
imagine if we rehabilitated instead of incarcerated.
Can you imagine?
I mean, that's one of the biggest things that we got to do. I know there's a big pushback against involuntary treatment, but there are studies that have shown pretty good benefit for individuals, and drug court having really good outcomes for certain individuals. You know, at the same time, I think decriminalizing personal use is a must. We have to get to that point. I think the idea of criminalizing somebody who's, you know, got a small amount of cocaine, or not too long ago, a little bit of pot on them. Now, fortunately, we got past that piece, but decriminalization is important. But we also have to remember removing the criminal aspect of a health disorder. What we all agreed, I mean, your viewers seem to agree as well. This is a health disorder. Why is it criminalized? And that's what we have to do, is we have to remove the criminalization aspect of it and bring compassion and understanding and education and allow people access for treatment. You know, the biggest stigma and barrier to treatment is the inability to ask, the fear of asking, the shame and the guilt to ask for help, the unknowing, where do I go to even ask for help? Where can I get it? I go to the Emerge, they don't treat me very well. No, that's shifting. We're starting to see some major improvements there. I go to my primary care physician, my family doc. They don't know what to do. They kind of look at me. Now that's shifting. We're seeing better treatment there and better outcomes. And our primary care physicians are becoming more and more educated and more compassionate and doing amazing. And so, you know, it's that first step. It's got to be okay to ask for help. Remember, not too long ago, you know, cancer was stigmatized. Nobody wanted to tell anyone that they had cancer. This was horrendous. And, you know, with the medical system, we were fine. But imagine if we treated addiction like cancer. We have a $1 billion building being built here in Calgary for cancer. We don't have no $1 billion building being built for addiction.
We have $120 million building being built in Saskatoon to put criminals in.
Yeah, well, see, yeah, you know, again, even if you did nothing at all, but simply turned your jails into a rehab center, you're already there. You can't go anywhere.
Yeah.
You may as well get treatment. I mean, it should
Absolutely.
just be a part of the process.
Yeah, you can't, and I say this almost every episode, but you just cannot punish the pain out of someone. You can't like charge them and jail them. And
some of the horrendous stories I hear of, you know, going into isolation and not getting your methadone for a couple of days as punishment. And some kind of horrible things that you sometimes hear. This is an opportunity to do. You could do so much trauma therapy, so much insight therapy, group therapy, learning about yourself, understanding who you are, doing good addiction, focusing on staying abstinent, getting some education. I mean, there's so many things we should be doing here, not just incarcerating for punishment.
Mm-hmm. So what are the biggest harms you're seeing in our society today?
Holy, that's a loaded question. You know,
I'll just put you on full screen here.
You
go.
We don't have drug policy, right? I mean, good drug policy has to include basically a complete revamp of the criminal justice system, a complete revamp of our healthcare system. You know, right now, things like psychotherapy and addiction counseling is not covered. That's insane. We need good public access to treatment. I mean, we need a universal healthcare system that gives a crap about addiction. And right now they don't. You need a universal healthcare system that gives a crap about your mental health. And right now all it cares about is getting a psychiatrist to write you a prescription. We need a universal healthcare system where it's universal, where, you know, mental health and addiction is a part of your health. It's not, oh, that's mental health. Oh, because the brain's not an organ. Like, I mean, it's absolutely ridiculous. It's preposterous to believe it. So we need a revamp of our healthcare system, a revamp of our criminal justice system, from drug courts to decriminalization. We need, you know, just as strong of the harm reduction policies. But, we need to ramp up some enforcement as well. Open drug use in front of families and in parks is not okay. If I tried to crack a 6-pack of beer in a park, it's not going to go well. But if I inject, I'm probably going to be let off just fine. And so part of those things that we need to have access to consumption sites where somebody can use, and if they're using anywhere else, we've got to support them. And that's kind of the Portugal model, right? The 4-pillar model, which was most of the money went into treatment, a decriminalization and criminal justice policy that shifted, increased enforcement, and harm reduction. And this isn't. We're not even talking about reinventing a wheel. We know that works. Why aren't we looking at doing something similar? Now, we've got patches of it throughout the country. And, in many ways, Alberta is leading the way. In many ways, other areas and jurisdictions have it a bit better. Some of the things that we really miss is the inability to kind of bring it together and everybody to work together. And as we talked about, that artificial divide between harm reduction and recovery is absolutely crazy. And what we should be working at is everybody working under one roof. Somebody's ready for help, they get help. Somebody's not ready for help, they're going to be in a position where their harm is reduced. And I think probably the most devastating thing we see right now, which just go onto your social media, you'll be able to see it. I left Twitter because of it. It was so bad. Is this artificial divide between recovery and it's, the harm reduction pundits yelling and screaming, saying, recovery capitalists aren't helping and they can't help and they won't help. And that's not true.
I believe we're all on the same spectrum. I believe abstinence is a harm reduction policy. Strategy.
The best, right? Is there anything that reduces the harm more than not using? Nothing.
Well, I mean, if the person's ready for it, if you take that person's person's dope away and they're not ready to quit, then the harm to the community can go through the roof.
Of course. And that's a big different process.
Yeah.
We need the compassion to intermix with this, and that's by treating it like a health disorder.
We're all on the same spectrum. We are all, it's one big 100%. Spectrum. Absolutely. Yeah.
100%. We have to accept that when somebody's ready, they should get access immediately.
Well, we're an impulsive bunch. I mean, like when I wanted to quit, it had to be right now, because in 5 minutes I'm going to be off in the sticks again. So if I have that one brief moment of clarity and I know the phone number to call and I can call it for free, like that's what we need. That I don't know how else to. Yeah, and I'm in.
Not only call it for free, they're telling you, okay, go to this address, we'll have you.
We'll send a taxi. Yes, see?
Fucking right.
We're thinking of this. We're on the same page,
That's
my friend.
Exactly how it should be.
Let's fucking do it.
If I'm in a safe consumption site, a supervised consumption site, and I decide, you know what, I think I don't want to do this today. I want some help. Somebody should be there, right there, immediately. Like not, okay, well, we'll walk you over here and we'll refer you to this program, and that program will call you in a few weeks.
In a few weeks, yeah.
It's done.
So if we think about it, okay, so how much does a stab wound cost? How much does it cost for first responders to respond to a home invasion?
How much does it cost for them to respond to an overdose?
Exactly.
Over and over and over and over again. And this individual has nowhere to go.
That's right.
It's horrific. The way we treat it, the way we do it, the way we are, it's horrific. And, somebody shows up to detox and they get in line and you have someone randomly picking to decide who gets in and who doesn't.
Call back every day.
And off they go. And they're told, come back at 7 a.m. But if you went there at 4 p.m, half that place may be empty because they discharge a bunch of people. Why wouldn't you be calling people in then? Mm-hmm. Oh, it's too much work, and we have policies and pathways, and we've got these
boxes. We've got these boxes that we have to check, and if we can't check a box, then we just don't know what to do.
The red tape of a public healthcare system, as fantastic as universalization is in healthcare, it also leads to a lot of bureaucracy.
Many of them care more about their parking spot than they do about the people they're supposed to be caring for. Did I? Oh shit! My mic was on.
You said that one. I didn't say that.
Did I say that shit out loud? Oh, sorry. Okay. Let's see. What else do we got here? We could go on about this all night, but we better move forward. Tell us about the Newly Institute.
Yeah. So look, I mean, I've been lucky enough to really work hard with the public healthcare system, with ministry all the way up. I was able to develop a really good surgical program to improve surgical outcomes for spine surgery, a really good deprescribing program for opioids to help people with chronic pain and addiction completely recover. The Rapid Access Addiction Medicine program, which I've worked with Dr. Monty Ghosh to develop. We've just got some funding thanks to our current minister. And really, we fought for many, many years, 5 proposals, 3 years, 2 governments. It took us a long time to get that funding, but now we're the largest addiction medicine outpatient program outside of CAMH in the country. And every time you're doing something and you're developing something, the public system wants to tell you, actually, we don't want to do it that way anymore. And it doesn't fit this box and it doesn't fit that box. So we're going to change it on you. And eventually, I got to a point after an argument with a manager. These aren't leaders, they're managers. So they're very good at scheduling, but not very good at leading anyone or believing in anything. Mm-hmm. And that's who we all have to work for. And I finally said enough is enough. We can do so much better, and we're going to go do better. So I called up a colleague of mine, Dr. Marshall Roche, and the two of us put together this protocol for prescribing Suboxone in emergency departments. And Alberta is still the only province in the country where every emergency department you can get prescribed Suboxone if you're feeling unwell. You could just walk in and they'll help you right then and there.
That's amazing.
But he agreed, and he's tired of the system, and we started kind of working down this pathway, and that's where the Newly came into existence, where the focus is, we're an addiction program, but the real focus is on traumatic psychological injuries. What trauma affected you today? If you've got treatment-resistant depression, what childhood trauma is affecting your treatment? What traumas are happening? So we've really developed a trauma center. And of course, in medicine, if I say trauma center, that means helicopters are landing after motor vehicle accidents. I'm referring to psychological traumas, and that's what we've developed. And medically managed, so everybody gets a psychiatric assessment, an addiction medicine assessment, a pain medicine assessment, and we treat all 3 of them under one roof. And the ultimate goal is to help people return back to work rapidly. So get them in quickly, get them well quickly, get them back to work quickly, get them back to the people that surround them at work. Work is one of our major social enterprises. It's where most people's social networks belong or exist. And so we need to get people back to it as soon as possible. And that's truly what the Newly Institute is it's a medically managed intensive outpatient program dedicated to people suffering with trauma, whether they have addiction or they don't have addiction, and they have chronic pain or they don't have chronic pain. That's what we're treating. And we're the first of its kind in this country. In fact, the American Society of Addiction Medicine has a protocol to help docs and nurse practitioners and addiction counselors determine placement of a treatment of an individual. And there are no medically managed intensive outpatient programs on their algorithm because they didn't exist. And so we're really that true first one where, rather than waiting to see a doctor maybe, or just going to a physiotherapist or seeing an addiction counselor, you get the whole shebang, and then you do intensive treatment. And that means doing trauma therapy almost every day for about 4 to 6 weeks, and intertwined with mindfulness and yoga and drumming circles and dialectical behavioral therapy, which is about learning skills and coping skills.
You have drum circles at the Newly Institute?
We're doing drum circles at the Newly Institute. Not only are we doing them, but we're actually recording algorithms and trying to determine, are there certain algorithms that work better than others? So we're not just doing them, we're collecting the data behind them. And we're going to learn everything that we have. We have a full research program built into it where everything we're doing is based on outcomes and data, and we're adjusting all the time. And even better is we have an alumni group that can tell us what we're doing right and wrong. What is and isn't working? What do you guys think about this? What do we need to change? Why do we need to change it? And we can change it tomorrow. We don't have to wait for this person to agree with that person to go up this ladder, up to that ladder. We just do it tomorrow. No, that's not
the dream.
It's
so
done.
you don't have a board of directors. You're all private, or how are you nonprofit?
Yeah, we're private. Our board of directors could care less about what the clinical outcomes are, what the clinical treatment is.
So the board just gives you broad strokes and says,
Correct. Well, at the end of the day, so there was three of us that were the main founders, and what we did was bring in experts from across the country, from the BCCSU to CAMH to everywhere else in between. And we brought in the best of the best to sit down and develop a protocol that makes sense, that focuses on all aspects of recovery. And that's what we've created. And we really, I mean, from the head of the Toronto Maple Leafs Wellness Center to the person who's been running the BCCSU training program, to the medical, the first author of the ketamine guidelines for Canada. All of these individuals are a part of our advisory or treatment programs. And we've just brought in the absolute best to develop nothing but the best. And then we brought in the best clinical team, many of them who formerly worked at the Operational Stress Injury Program, which is kind of Canada's VA system, and including their clinical lead, who really built the Calgary OSI into one of the largest in the country. And has spoken around the world for her innovation. And she's our chief clinical officer. I mean, we've brought in a former Surgeon General who's our compliance officer, to the former chief of psychiatry for the Canadian Armed Forces, who his entire expertise is treating PTSD. This is all he does. And so we've brought in the best of the best to provide care for the people who deserve it most, really focused on our first responders, especially during this horrific COVID pandemic. So our focus is police officers, EMS and ambulance paramedic, nursing, healthcare providers, fire, everybody who's out there and dedicating their lives for all of us. It is our duty to give back and do the exact same thing for them, including for veterans who have fought overseas and now wondering all that time in Afghanistan for what. And so, you know, our whole program is dedicated to supporting those who really, you know, are the true heroes in our society today.
Mm-hmm. So, so you're an outpatient program. What do you do with your clients when they go home? Is there support available for them when they're not in the Institute?
So that's a great question. What we want is people to stay at home. So they come in, they do their 5 to 8 hour day with us, and then they go home. And this way, all of the discomfort and difficulties and the marital difficulties and the family difficulties and the workplace difficulties, they don't magically disappear because they get to go to a fancy inpatient program. Mm-hmm. They're all there. And we're going to help them through it and help them go through it. And of course, our level 3 or post-treatment follow-up goes on for 1 year afterwards with weekly follow-up. So we don't just, you know, intensively treat, we follow and make sure they're stable after. And then of course, we've added an annual checkup from the neck up. So once a year, somebody's going to give you a call. We're going to book an appointment. We're going to see how you're doing, what's going on. And if there's anything going on, then we'll make sure that we support you getting further support or help. And if somebody can't stabilize in the community, then we've been working really hard with some of our partners who do have inpatient programming, but also focus on psychological injuries and trauma. So true medically managed inpatient services. And we've had some great relationships with, you know, places like Edgewood Health Network and stuff like that. So really working hard to make sure there's a great continuum of care, so that no matter who you are, you get the best that you really deserve.
That's amazing, man. Let's go into the viewer's voice. Here we go. I saw you talking there during the viewer's voice, but I didn't hear you. The mic was muted.
Oh, I just said I got you speechless. So
you kind of do, man. You kind of do. Yeah. Okay. You can have this one. You win this round, Doc. Okay. Wow. We got a lot of questions. Oh, and we can only go back so far. Okay. Let's see. Where do we go? Well, there was one here. Where is it? Oh, it went back too far.
Post it again.
Holy cow. We've got 5 pages of comments.
Oh, well.
I've never seen it go past. Oh, here it is. Here it is.
All
Here's
right.
the one. My favorite one.
Okay.
Yes. I forget what, but yes. Definitely. Thank
All
you,
right,
Wilmina.
we're tied. 1-1.
I agree. Yes. Yes. Thank you, Wilmina. Okay. So, oh wow, how am I gonna? Oh, here's one from Marie. Marie has a
Right.
comment. It's not gonna all fit on the screen, I don't think. No, it won't. I'll read it. I met with the justice minister and said, "You have the infrastructure prison, split it down the middle, and offer long-term addiction programs for reduced sentences." He said it would never work because essentially the base wouldn't agree with it. Ugh.
Well, Marie, here. Good for you for at least going and trying. You're not the only one. There's many trying to do the same thing you're doing. So, great work. I'd love to see something just like that.
We've got Ange saying Twitter is bad for the mental health.
Yeah, Angie, I 100% agree with you. It's funny because, I still dabble in Twitter, just not. I canceled my Twitter account and had a pretty decent following. But I mean, it's like, listening to someone say injecting bleach cures COVID and, this is going to cure the opioid crisis. And if you don't believe me, you got to listen to me. And, all these people trying to tell me how to do things. And it really truly represents the silent or the vocal minority and doesn't really allow you to understand what's going on in real life, the true silent majority. Mm-hmm. But thanks, Angie.
We've got
it's bad for your mental health.
We've got a comment coming in from Sox Malone, and I'm sorry. They say, tell us about the Alberta model. I hear it's leading the country.
I think there's a lot of great things that are happening in Alberta, and they've been happening for a long time. The first thing is, a lot of the beginning of what to do started with a strong harm reduction and supervised consumption services model. And from that point, we've seen just a significant emphasis on building treatment. And what we're really excited to see coming soon is these recovery communities. These will be free 1-year inpatient treatment programs. So we're really excited to see that. Right now, Alberta is one of the few places in the world where inpatient addiction treatment is free. We have a full virtual opioid dependency program, so anybody can pick up that phone call and start on Suboxone or Methadone today. That's again such an innovative and amazing program developed by Dr. Nathaniel Day, who's done an amazing job there. The ARCH program for inpatients, as well as some other addiction programs for that. The RAM program, which we now have a specialty link so we can support all primary care physicians looking for a consult. We've really seen massive movement. Now, the big thing, like I mentioned before in Alberta, is trying to bring that all together and having everybody move together. And we're starting to see that already. And we're starting to see a movement of ministry wanting to work with the physicians. And I think the big thing that we got to do, and I think this is going to happen sooner rather than later, is we need a big national advisory panel full of experts who treat addiction and who've recovered from addiction. And really sit down and try to figure out, and families, of course, sorry, Angie, without question, we need families there and understanding from the family perspective, the spouse perspective, which is a big part of what we're doing at the Newly as well. We have a full family and spouse program, basically trying to support the caretaker in the relationship. So, I think the pieces of the Alberta model are pretty impressive and well beyond anything else that we're seeing in North America. And we just got to continue to see the growth and start seeing that interconnection and start seeing people working together.
We've got Marie chiming in again. Is it going to fit on the screen? Oh, I got to make my font smaller, I guess. Sorry, Marie, I'll read it off. The wait list for psychiatrists in Saskatchewan is over a year. 8 months for urgent cases. Mm-hmm. Government-funded mental health therapists are overwhelmed with work with too many clients. That is the truth.
Yeah, no, I agree. I mean, Marie, you're 100% right. And so this isn't much different here. Long wait list to see anyone. So what we've done with our rapid access addiction medicine program is we've got psychiatrists, addiction medicine, psychology, nurse practitioner, addiction counselors, nurses, admin, all working under one roof. And you can walk in and get help immediately. You will start treatment immediately if you walk in and ask for help. You can get a referral in from an emergency department, from a hospital, from an inpatient treatment program. We get a lot of referrals direct from them. You can come directly after being released from jail and come direct over, and we can continue treatment that you may have started there or initiate treatment for those who haven't started it. We have recovery coaches. So these are peers who are working on the street. Really awesome. If somebody doesn't show up for an appointment, they'll go find them. But here's the coolest thing of all of this. We have 2 full-time psychologists as well as about 6 counselors who are all trained in trauma therapy. So we can actually get people into trauma therapy. Now, we're just hiring the psychologist, so it's not all put together quite yet. We just got the funding. But the ultimate goal is to start people on trauma therapy within a few weeks of coming into treatment. Maybe even if we got to 6-8 weeks, we'd be pretty excited if we got that short of a wait to get into trauma therapy. And it's all funded and covered under the Alberta government system, under Alberta Health Services.
Got another comment coming in from Brent. Thanks for watching tonight, Brent. Brent says, stigma hinders looking at the holistic picture. We still blame the person, and the person blames themselves at a macro level. Oh, where are you, Brent? There you go. At a macro level, the government fails to ante up.
Yeah, look, I can't disagree with you. Again, imagine what would happen if we treated the current addiction epidemic like COVID. If we put that kind of money into it, that kind of energy into it, if we actually, kind of gave a shit. And right now, in most provinces, we're still seeing more deaths. Certainly in BC, Alberta, and Ontario, we're seeing more deaths from opioid overdoses than we are from COVID. And we still haven't really seen some of the things we need. Now, the federal election, we're starting to hear some more movement and push in addiction and mental health. And it'd be great if this was the primary issue. And it just, for some parties, it's not an issue at all. We haven't heard anything. And how devastating is that?
Mm-hmm. We've got Claudia chiming in. She asks, what is the basic difference between the structure of MDMA and LSD?
They're pretty different. MDMA has a bit more stimulant, so it's going to hit your serotonin, norepinephrine, dopamine receptors. A lot of the dopamine is going to get going. That's that stimulant piece. And LSD is primarily serotonergic. It hits those serotonin receptors really, really powerfully. But again, why does it have such an effect? It's hard to know. So the brain's pretty complex. Who would have guessed? But when you hit some serotonin receptors, you activate dopamine, and too much dopamine activation leads to hallucinations and delusions, and that might be a part of the process. But at the end of the day, LSD used to be a treatment in the 50s and 60s for alcohol use disorder, and we used it a lot. And we think that the hallucinogens, or what we're calling now the psychedelics, may be another breakthrough in addiction medicine. Is it a cure-all, end-all? No. No matter how much the biomedical people want to make you believe that this pill or that pill or access to this or that is going to change everything. These are people who don't understand addiction and mental health. It's got to be that good combination, but the psychedelics may be a big piece of that coming soon.
In response to your poll that you asked earlier, what was the question again?
Is addiction a health disorder?
Well, we've got Corey chiming in. Thank you, Corey. We've got Jenny chiming in. Thank you, Jenny. We've got Wilmina chiming in. Thank you, Wilmina. And Donna. And Townie. And
awesome.
And more. Let me just take one last scroll here.
It's time to start treating it like one.
Absolutely. Absolutely.
It's just gotta happen. It's just gotta happen. We've got to start treating it like heart disease and cancer, or COVID for that matter.
Yeah, I agree.
It's probably more like COVID because there's more opinions than evidence often. So some probably more similarities.
Well, everybody's got an opinion. Not everybody has COVID.
Yeah, everybody does. Everybody knows how to cure the opioid crisis. It could be a vending machine or a prescription pad or something simple, which we know is kind of ridiculous.
Yeah. Let me just do... Oh, we've got Wilhelmina chiming in here. She is saying prisons in Canada costs 100 to 200,000 per person per year. How much treatment can that buy us? How much aftercare could that buy us? How much housing? How much housing? You know, that's a lot of rent.
Yeah, I mean, to give you an idea, I'm talking about a private institution with the Newly Institute, and I'm going to plug again, and I apologize for that. So if we took, I'm just dividing here, we'd be able to treat between 6 and 10 people every year for that one person in jail. And that's in a private institute where you're going to get kind of the best care that's out there. I'm sure if the public system bucked up, it would cost more. But anyways, a lot more than what it costs us to put people in jail. I agree 100%.
We've got a couple more questions. Oh, yeah, we've got a few more questions here. Sorry, I'm trying to go through all of the 5 pages while you're answering. Anyways, Marie says, does Alberta require any physicians to take a multi-day course to become Suboxone prescribers? Hang on. I have to read it for the audio. So, it has been a barrier in Saskatchewan and other communities nationally. Not sure what the current state is. Take it away.
Yeah, the answer is no. So I was the medical lead for the development of our training program for opioid agonist therapy and other addiction programs. But the ultimate goal was always to advocate to remove it altogether, and anybody and everyone can prescribe it. And that has been that way now for many, many years in Alberta. You don't need to take any course. You are expected to do some sort of course in methadone, but you don't have to go to a clinic and spend a bunch of time in a clinic and all that. You can actually do it all online. As we developed an e-preceptorship, which actually ended up winning the most innovative CME of the year back in, I think, 2018. So we've really tried to eliminate all barriers to buprenorphine naloxone. And the next step is we got to get our community paramedics prescribing it. And I know there's some movement on that as well. So that's got to be a huge piece, is get the community paramedics, get everybody. I mean, should it be like fluoride and in the water? Maybe a little aggressive, but it should be as easy as that.
Fluoride, Suboxone in the water. That's
Suboxone in the water with the fluoride. That would piss some people off.
Well,
I say fluoride, that probably pisses people off. So.
Probably, yeah. Anyways, so again, we've got another one coming in here from Angie. Angie, thank you so much for all of the engagement tonight. We really appreciate you being here. If someone has bipolar, can psychedelics help with the depression portion if there is no trauma? Yes.
So it's been studied in bipolar depression. Absolutely works. So we would expect that would work just fine. Now, again, in addiction, I see bipolar thrown around kind of like coffee cups in an AA meeting. I think that it's overdiagnosed, overused, and most people who are struggling with so-called bipolar often are struggling with PTSD or other traumas. Now, that's not for everyone. There are certainly a percentage of people who have true bipolar disorder and are struggling. But there's without question the psychedelics, or specifically psilocybin for the treatment of bipolar depression that is treatment resistant, has evidence.
And one more from Angie. Is the
Angie.
newly... Oh, yes, she is full of questions, and we love her for it. Same with all of our viewers. Is the newly just using ketamine now? Will it be using magic mushrooms in the future?
Yeah, so right now, ketamine-assisted treatment is a third-line treatment for treatment-resistant depression, and so our psychiatrists use it as such. Outside of that, psilocybin, MDMA, we have research protocols in place that we're working through Health Canada ethics, all of the processes that need to be done. So they'll all be researched until they have a DIN number and they can be prescribed legally. We are a full medical program, and so everything that we do is in a medical and under the auspice of medicine, and hence we're unable to prescribe anything that's illegal unless it's under a research protocol. So we have 3 different research protocols that we're hoping to have all approved, and then I could speak freely about them.
We have Marie chiming in. More of a comment. We have to wait till these guys age out of politics.
Yeah, there's just another one coming in. I'm not sure it works that way. So, we are seeing change, right? We're starting to see, the fact that, 2 of the 3 leaders have kind of come out and talked about the need for better addiction and mental health treatment is pretty impressive. And I think the 2 of them have also put some pretty good sized money behind what they want to do. So we need more of these, these therapeutic or recovery communities, 1-year programs. We need immediate access. We need access to treatment for youth and children, which is probably one of the biggest gaffes in this country right now. Is if you're a 15-year-old and you need help, you're going to really struggle to find anything out there. So we've got a lot of work to do. But I'm excited to see, that it's made it into the election and that people are talking about it. Because not too long ago, that was unheard of. So I think we're starting to see the shift. Well, That's my positive look at it.
Wilmina's chiming in again. Are you specifically dealing with benzodiazepine addiction? It's a tough one.
It is a real tough one. And I think it's one of the biggest problems that we're seeing right now on the street is the so-called down, which is often fentanyl, is being mixed with different benzos, some of them illicit benzos. And now we're just seeing some real difficulties in reversing overdoses because the benzo is on board that's complicating the overdose. And we're seeing a lot of addiction there. But, straight benzodiazepine addiction is also really difficult. And yes, I treat a lot of that. Often most of this starts with a prescriber, similar to where opioids often started. So, yeah, we're working on that. But benzos are like opioids. You just got to do it real slow. You got to taper it. You got to prescribe for them. You got to just slowly chip away, and you've got to add in the good mental health care. There's a reason they're taking the benzo, and that needs to be treated appropriately. Just like there's a reason they're probably taking the opioid that also should be treated appropriately.
Claudia's chiming in. How about pharmacies prescribing Suboxone?
Yeah, totally. Totally. You know how many times I've yelled at a poor pharmacist? I wrote a prescription, and I usually leave my prescriptions open because maybe they're not quite ready. But just in case, we had a pretty good conversation. I let them know the prescription's sitting there. And there's still pharmacists out there that are like, oh, they didn't pick it up, so we canceled it. It's like, well, no, don't ever cancel it.
They're sick. They're sick. So, and they were displaying symptoms of their illness, so we canceled their prescription.
Correct. They came into my pharmacy and they only asked for the Suboxone. Well, that's awesome. Like, I don't really care about,
what were they supposed to ask for?
Sleep medication and whatever else they've got prescribed. They're asking for their Suboxone. This is someone who's finally saying, just like we talked about, I'm ready now.
Right now.
Do it now. Yes.
Fucking
right
go.
Now. Exactly. That's exactly what it's got to be.
We've got Donna chiming in. I was once told I am bipolar based on my usage pattern, substances of choice over the years. What have you got to say to that, Doc?
I just said it.
Ah, yes. Well said.
Yeah. I'm sorry, okay. Donna.
Yeah. Donna's a warrior. She's something else.
Good.
Yep. Let's see. What else do we got here? Claudia, her nurse practitioners can prescribe narcotics now. Wonder if they can prescribe Suboxone too.
Some of our best physicians / NPs in Alberta are nurse practitioners. Some of our best addiction medicine practitioners are nurse practitioners. And I've been lucky enough to work with several of them. Without question, not only can they prescribe it, they can prescribe methadone, they can prescribe Cadian, they can prescribe IOT, they can do all of that. So, as they should, many of them work hand in hand with us. And there's some incredible NPs out there.
We have Brent. I love this question, Brent. Thank you. The Newly model should be standard of care. How can we advocate to push government to stop putting Band-Aids on our problems? Brent, you can subscribe to Hard Knocks Talks and follow us on all platforms.
I love it, Brent. I don't know. I mean, honestly, the first step, we're working with some of the WCBs across the country, several of the large insurance companies, from Sun Life to LifeWorks. We've had some great relationships, and there's a lot of people really excited to be able to refer to us and get that treatment done. I would agree 100%. I mean, I would love to see a minister step up and say, "Hey, this is exactly what we want to get done." But
Rob was
once
right.
That happens.
Rob was right. Yeah.
Not quite that far, but I don't mind that part. But it would be fraught with, why are they getting this, and why would we? There would just be some controversy if it happened quite that easily. But I agree 100%. I think that sometimes there's a viewpoint. Our universal healthcare system is the floor, not the ceiling, and we should be pushing for it to have no ceiling and to innovate and grow and have the best of the best. But I just want to say thank you for such a kind comment, and we're really excited that we're able to help people the way we do.
Okay, my friend, the comments have slowed. Is there anything that you would like to leave us with tonight?
I'm gonna steal. I do this all the time, and he's a great guy, Omar Manjawala, who's a big addiction doc down in the U.S. and ran some very large facilities. He left us with a comment when we were presenting together in a conference, and the comment was something I'll never forget. Imagine a world where it was easier to get help than to get high. I think that is my ultimate goal. And until we get there, we're just doing the wrong thing. And we can't make excuses like trauma therapy is inaccessible, so we need to do this instead. No. We need to advocate for trauma therapy. We need to advocate for better treatment. We need to advocate for access to detox. We need to advocate for inpatient treatment. We need to advocate for outpatient treatment. We need to advocate for level 3 addiction programming or aftercare. People should be okay to go ask for help. They shouldn't feel stigmatized or judged. They should just be looked upon like somebody with high blood pressure or a raging infection. This is someone who needs help. It's our job as a healthcare system to help them. And right now, we're not quite there. And I sure do hope that's where we go, is that one day it truly is easier to get help than it is to get high. And Dan, man, I want to really thank you. We've had some great text conversations and phone call conversations, and I've been really looking forward to this. And what a great audience you have, some insightful questions. You got some real thinkers, and I'm really excited to see just how far Hard Knocks Talks gets, and love to see it number 1 in the country.
Oh, man, we'd love to see that too. And we look forward to all the things to come with the Newly Institute and everybody else who's getting involved. It's been truly wonderful. Thank you for joining us tonight. And
absolutely.
And take care.
Check out thenewly.ca. Go check it out. See what you think. Love to hear your comments.
It is, the link is in the chat. In the
Great.
5-page. Do you want to throw that link in there one more time, bud? We're going to throw it in there one more time. So check it out. Okay. Thanks a lot, Dr. Rob.
Awesome.
We will see you again sometime. Take care.
Thanks, everyone.
Fostering change is our primary purpose here at Hard Knocks Talks. If you would like to contribute to ending the pain, ending the stigma around emotional pain, please subscribe to our YouTube channel. Follow us on LinkedIn, Facebook, and Instagram. Like and comment your thoughts on our posts. Let us come together with our lived and living experience as a resource that has the power to engage new thought processes, to promote new ideas, to broaden the spectrum of care, and to show the world that the lie is dead. We do recover, and we're here to show you how. Good night.
Mm-hmm.